Hello everybody. So here is the answer to today's quiz. The first question is essentially just a picture showing a 40-year-old male who presented with multiple lesions on the glans penis, which he's had for a number of months. These are asymptomatic. Okay, so what you're seeing here is sort of flat-topped papules quite coalescing together to form small plaques, slightly violaceous. Initially, this was thought to be lichen planus clinically or psoriasis, but failed to respond to topical steroids, and hence a biopsy was taken. So here are the histological images. So in the first low power image, what you see is marked acanthosis. Okay. Now you can, even on low power, you can make out that there's few coilocyte-like cells here. Okay. Basal hyperchromatism, so the nuclei seem to be hyperchromatic here, and yeah, there is acanthosis. Definitely the epidermis is thickened. There is no significant spongiosis. There is some parakeratosis here on low power. Not much inflammation. Now these are small blood vessels which you expect on the glans penis, because penis is quite vascular. You'd expect an increase in vasculature in the dermis. So on higher power, what you're seeing here is the same thing on what we saw on low power, accentuated. You're seeing hyperchromatic nuclei. So the basal layer cells are not strictly polarized, in the sense that there is lack of polarity. The cells seem to be migrating upwards. And you can see here slightly atypical cells as well, hyperchromatic nuclei, some pleomorphism. The cells nuclei are not similar in size and shape. Some are small, some are large. In the higher power, you're seeing the coilocytes a bit more accentuated. Now you may wonder if these are actually true coilocytes or actually an artifact of processing, because these sort of vacuolated cells are present at the edge of biopsy. Sometimes when you at the point of infiltration of local anesthetic or trauma, you may find these sort of vacuolated cells, but I think they are pathological personally. Coilocytes also should have sort of hypergranular. There should be increase in granular sort of granularity as well. So they're also hypergranular. There's no granularity here within the cytoplasm, and the nuclei are not quite steel gray. So this is slightly debatable. Sometimes it can be tricky. I have therefore not deliberately questioned you on this. But what you're seeing here, more obvious, is these sort of atypical cells here, hyperchromatic, quite abnormal nuclei. These are not normal. You can see sort of a mitotic figure here as well. So there is definite loss of polarity, hyperchromatism, nuclear pleomorphism. This is extending to the mid-dermis and sort of mid-epidermis and to the higher levels of the epidermis as well. So this is definitely pre-malignant, if not malignant. So this I would definitely call it in situ malignancy. And of the choices given, the in situ malignancy here is Bowenoid papulosis, which is usually of viral origin. Psoriasis, lichen planus are all inflammatory conditions. There is no inflammation here. Viral warts, you may think about it, but then there is such marked pleomorphism and atypia of the epidermis is not seen. Squamous cell carcinoma, you should see infiltration of the dermis, which you're not seeing here. So you can exclude that. Zuhn's balanitis, again, is more of a spongiotic condition with lots of plasma cells. Again, that is excluded. Thank you.